Hello, and today I'm with the amazing Dr. Liz Jackson. She is an absolute powerhouse in obstetrics and gynecology, and we're going to untangle some of the most important, confusing, and sometimes overlooked topics in women's health, from PCOS to menopause, IVF, and we'll just see how much we can get through. So I'm very grateful that she's joined me today, and she is a long-term friend and a fabulous support in everything I've done in previous years. Hello, Liz. Thank you.
Hello, Lynn. Thank you so much for having me.
Can you tell me a little bit about yourself? What is your brief CV?
I am friend and colleague of Dr. Lynn Reid.
No. You're underselling yourself.
I'm an obstetrician-gynecologist. I work as a private practitioner from Cairns. I grew up in Brisbane. I went to Monash Medical School, currently completing my MBA. I've previously completed a Masters of Clinical Reproductive Endocrinology and Infertility, a Masters of Minimally Invasive Surgery. I'm a robotic surgeon. I'm the Vice President of the National Association of Specialist Obstetricians and Gynecologists. I'm a Royal Australian College of Obstetrics and Gynecology fellow. I'm a training supervisor. I'm an examiner. I'm a RACP supervisor, and I am mother of two beautiful babies, and wife to husband number one. And I am a keen kayaker, outdoor adventurer, and I am sister to too many brothers and sisters.
You come from a big, gorgeous family. Look, I want to delve in really quickly, like that. What a CV, and we are so lucky to be able to pick your brains. As a GP, I see heaps of women's health, and I appreciate the complexity of it. So I wanted to have this opportunity. I've got such a back catalogue of interesting, complex, curly patients. So I'm loving this. So I want to start by walking through just the basics, if you will, the female menstrual cycle. Like what's happening hormonally through the month, and how does things like PCOS disrupt this natural rhythm?
The female menstrual cycle is very fascinating because it begins when you are a baby inside your mum and you are 8 weeks of age as an embryo. And that's when your reproductive tract will form. By approximately 20 weeks of embryonic life, fetus weighing approximately 500 grams, you will have about 500,000 eggs. By the time you're born, you have 200,000 eggs. By the time you reach puberty, you have 100,000 eggs. And every month, your body recruits eggs, approximately 200 a month. Those 200 take about 3 months to get to the final stages. And this is where I like to describe the female menstrual cycle as the Miss World competition. So by the time you have your period, when you see menstrual blood, you're down to the final 12. And there's this fantastic thing called the hypothalamic-pituitary-ovarian axis, which I love. And it's a very fascinating interplay of physiology. And what happens is when you're a teenager, your brain gets big enough that these glands start to turn on. So the waterfall starts and it starts to spill down the different pools. So your hypothalamus starts to talk to the pituitary and the pituitary starts to talk to the ovary. At the start of your period, the pituitary taps the ovary on the shoulder or on the eggs, and it recruits about a dozen eggs. They grumble along for a few days and then your body picks one. The first thing that one does from that final dozen in the Miss Universe competition is it kills the competition. That leading follicle atrophies, gives a kill signal to the other ones, and they die off. They're microscopic. You can fit 1,000 eggs on the tip of a pin. When they die off, they're never to be used again. So slowly over time, your body has less and less. By the time you reach menopause, there are no more eggs remaining. But what happens to that leading follicle, it then undergoes a fascinating process, and it looks a little bit, once it gets chosen, like a chicken egg. The real egg is like the yolk, then you have the egg white, but most fascinating, you have the shell. The shell of the egg will enlarge, and it's the shell of the egg that makes estrogen. Estrogen makes the lining of the uterus thicken. In gynecology, we talk about day 1 of your cycle. Day 1 is the first day that you see blood. You pick this leading follicle between day 3 to day 7 in a 28-day cycle. After you pick the leading egg, it starts to ripen, the estrogen level goes up, and the lining of the uterus thickens. In the middle of the cycle, there is then a surge, and that surge results in the egg being released. And if you're going to conceive a pregnancy, the oocyte will be will be fertilized in the fallopian tube. The really interesting thing is the shell, because the shell in a human will reform. And when it reforms, it then makes progesterone. The role of progesterone is to support the lining of the pregnancy so that when that embryo implants, it stays nice and stable. If you're pregnant, progesterone levels stay high, they maintain a pregnancy. If you're not pregnant, the progesterone level falls, and that is the trigger for a period. And so PCOS, that doesn't happen. So what happens with PCOS is there's a inability to pick a leading follicle. So those dozen little oocytes back at the start of the cycle still just grumble along. And over time, your body will keep sending signals and you'll accumulate on an ultrasound the appearance of lots of little follicles or little cysts on your ovaries. If you don't pick a leading follicle, you can't develop that one egg. You don't have the trigger after you ovulate. You don't have the progesterone being made to be able to, if you're not pregnant, tell your body to have a period. So women with PCOS present with irregular or no periods, but also they can present with ultrasound appearances of multiple follicles on their scan.
Yeah, and I was reading more recently that we're moving away from that sort of polycystic, because it's actually multi-follicles. Is that, I mean, it's all terminology.
Yeah.
Do you need to see that on ultrasound to diagnose?
No, you don't. So then there's another feature with PCOS, which is that you can have increased androgens. Androgens can present either that your blood tests show that your hormone levels are raised for things such as testosterone, or you can have symptoms of increased androgen, which can include facial hair or acne. There's something called the Rotterdam criteria, and that is accepted worldwide as the threshold that PCOS is diagnosed, and you only need 2 out of the 3. So if you have irregular periods with facial hair, if you have an ultrasound scan with regular periods but acne, you actually meet the 2 out of the 3 criteria. The other final component of diagnosis is that you don't have anything else that can be mimicking PCOS. Examples could be maybe you're pregnant. Maybe you're going through early menopause.
That's a careful one, isn't it? You don't want to be missing
critical.
that.
Absolutely.
As a GP, I think often we'll see these irregular periods, patients presenting. At the back of our mind, we should always have that there as a, is this early ovarian failure rather than the PCOS? And I think we now are so familiar with PCOS that perhaps there's an element of us sort of forgetting a little bit about that.
And that's where we come back to that hypothalamic-pituitary-ovarian axis. So there are other things, anything that interrupts anything from that HPO axis can mimic PCOS. Examples would be breastfeeding. So you have raised prolactin levels that can mimic it. Alternatively, you can have, if you were having protein supplements that had any DHEA or DHEAS in them, protein supplements, particularly I've found vegan protein supplements can definitely mimic PCOS and turn off your menstrual cycle. Also, you can have pregnancy mimics PCOS. There's a few things that are very critical.
Microprolactinomas and things like that as well.
There's many things. So you need a blood test to exclude other conditions. So you meet 2 out of 3 of the Rotterdam criteria, exclude other conditions. And then once we've established the diagnosis, we target therapy.
How do you address PCOS holistically? Like considering the metabolic health, mental health, skin, fertility, there's a lot in there. And I think as GPs, we'll often navigate that with our patients, especially around metabolic health. I do a lot of work with patients for lifestyle management, weight loss. I look after a lot of acne in my student health role. But the fertility, that's a big anxiety. What's the take-home message for patients with PCOS in terms of what can they expect? What's to look out for with PCOS, and what's the things that they should be thinking about as they approach that sort of time in their life where they're maybe thinking about falling pregnant?
So with PCOS, first of all, be very hesitant to receive this diagnosis under the age of 20. And the reason for that is because the maturation or the maturing of your hypothalamic-pituitary-ovarian axis takes a few years. So we all remember when we first got our periods that for many years, maybe 4 to 6 years, you may have irregular cycles. You may have acne as a teenager. These things are normal. So under the age of 20, if you're considering the diagnosis, consider seeing a gynecologist. There are 3 things you need to consider with PCOS, and it depends where you are in your life, which ones we concentrate on. First of all, we have fertility. Next, we have the menstrual cycle. Finally, we need to think about the risk of endometrial cancer. So let's start with fertility. If you are not planning on falling pregnant, please default to talking about the periods in a moment.
I will.
If you are intending to fall pregnant, it can be very difficult with PCOS to know how to use the fertility app. They don't apply to you.
Right.
Have sex 3 times a week. If you haven't conceived within 6 months, see a gynecologist. You may require ovulation induction if your periods are irregular. There are 2 medications mainly used. Most people these days would use letrozole to help your body pick an egg. So those critical days when the Miss Universe competition is on, we're trying to pick a winner. We're really looking for the golden egg, so to speak. Then next of all, there's another medication called Clomid. Australian gynecologists don't often use that much anymore. It is seen overseas more frequently. We consider letrozole to be that little bit better.
I see that with my international students here. They'll often have that as their default position. They've had it for previous pregnancies and things.
So the letrozole's just got slightly better advantages. And then, look, there are some people sometimes we need to use IVF drugs to help stimulate their ovaries. Under incredibly close conditions, we can supervise the very low dose use of an IVF to stimulate ovulation. But there are a number of women that may require IVF to help conceive, and those women are more commonly than not what we dub skinny PCO. There's 2 ways that the body develops PCOS, we think, and those 2 main ways. The first is that through body fat, produce insulin, and that insulin is somehow plays a role in inhibiting the selection of an egg. So for women with a BMI over 25, you might consider the role of weight loss. But there are many women that we dub skinny PCO, meaning their BMI is under 25 and yet they still don't ovulate. And for those women, we would recommend that, like those women, the actual cause is that within the ovary there's something like insulin-like growth factor inhibiting the selection of an egg.
And it's interesting you say that, because I see quite a lot of patients who, with PCOS, actually do quite well at getting their periods not so badly managed, but actually falling pregnant with a bit of metformin. And it's like you think, metformin, it's been around for donkeys and it's done its rounds 1,000 times over. But often patients will respond quite nicely. I mean, you don't want them falling into that sort of comfort zone of that will be enough.
Metformin only has a role in women.
Insulin resistance or
women with a PCOS with a BMI over 25. If your BMI is under 25, metformin won't resolve that.
Exactly.
The way they think metformin works is that it causes a bit of a tummy upset, which helps you lose weight. And the loss of weight can help recommence the ovulation process. With women trying to conceive, if you do not have a period, if you stop the pill and don't have your period back within 3 months, or if you haven't been on the pill, if you are trying to conceive and you have not had your period for 3 months, obviously check that you're not pregnant. And if you are not having a period, trying to conceive for 3 months, see a gynecologist. Yeah. Well, of course, see your GP first.
But historically, GPs and the world over, we've kind of tortured women a bit by saying, try for 12 months.
No.
Yeah.
Not if you have underlying medical conditions. Specifically, no period for 3 months, trying to conceive with known PCOS for 6 months. Do not wait the full 12 months. If you are over 35 for more than 6 months, if you're over 40, consult a gynecologist immediately.
Well, I'm going to ask you a pressing question then, because I do sometimes see patients over the age of 35 who've come into me and they're of the higher BMI phenotype for PCOS, and they're on a mission to lose weight for IVF. What's the take on the benefit of losing weight and that offset against the ticking time of fertility?
So spinning away a little bit away from the PCOS, so the role of that, so reduced weight loss would assist with, first of all, natural conception, because if, for example, your BMI was interfering with the selection of an egg with PCOS, you may commence ovulating again 50% of the time with a 10% weight loss.
10%.
Next of all, pregnancy outcomes. Increased BMIs are associated with adverse pregnancy outcomes, including cesarean sections, instrumental delivery, shoulder dystocia, gestational diabetes, and other anomalies of the baby. Yeah, the full works. And then finally, depending on the BMI, even with IVF, you may be prohibited from having your procedure. There are BMI cutoffs for day surgeries where IVF is performed. Very commonly, if your BMI is over 35, there will be some degree of restrictions. Day hospitals are not designed with the full complement of medical resources available for increased risk surgery, and so you may struggle over, especially with BMI over 35, but particularly a BMI over 40, you may find that IVF is not accessible to that.
But I think actually, that landscape's changing. We now have GLP-1s, which seem to be game changers in terms of attaining a healthier weight to facilitate women accessing these treatments. And it's not just IVF, it's obviously for surgical operations and so forth out with that.
So I guess the other thing to mention just quickly is menstrual cycles. You only need to have a period to have a pregnancy so long as your body has endometrial stabilization. Your body needs to have at least 4 progesterone-mediated withdrawal bleeds per year to reduce your probability of endometrial cancer. So PCOS is associated with more heavier periods. It's associated with more irregular periods. And what we recommend is that people actually take control, and control as a woman is never given to you. It's never gifted to you. So take the control of your menstrual cycle. There are many safe ways to help skip your period so that you do have control. Nature is not always kind to us. Examples of ways to manage your periods include the oral contraceptive pill, if that's safe for you. It can include the newer progesterones, which turn off your period. Examples would include Vizan or Slinda. You also have what we would term long-acting reversible contraceptives. Really, it's for menstrual management. And you've got profoundly effective ways to manage your periods with PCOS, which includes the Depo-Provera shot, Implanon, the Mirena IUD, and then also you can utilise the copper IUD. And finally, you are of increased risk of endometrial cancer as you get older if you have PCOS, particularly if you don't exercise some form of control of your endometrium. Ideally long-acting reversible contraceptives, but there are other ways to reduce that endometrial cancer risk, including weight loss, for example.
We have literally scraped the surface. That is the tip of the iceberg. Women's health is so complex, but it's so incredibly interesting. And I know there's lots and lots and lots of women out there and GPs who want to know more about this. So we're going to wrap up today. And thank you so much. I'm going to pick your brain. You're going to be back. I want to hear more. We've still got endometriosis to talk about. We've still got a huge amount of menopause and perimenopause.
Can I recommend one thing?
Go on.
Australia has absolutely superb guidelines for PCOS. They were formulated down south of Queensland. Michael Costello headed the PCOS Working Party. They've been adopted by the Europeans and by many other
Where can we get these?
It's a downloadable app or alternatively a website, and it's called Ask PCOS. So I firmly recommend, please don't ask Facebook, ask PCOS, and you will find many answers to many questions.
And is this for
everybody, Lynn?
Liz, thank you so much. Ask PCOS.
Yeah.
Let's do it.
Yeah.
Thank you, Liz Jackson.